We've heard a lot about data and then also opportunities that are going on across the nation to continue to address maternal and infant health. And so our next session is on maternal and infant policy. And it is my pleasure to introduce the next group of respected advocates who are experts in the field of maternal and infant health policy at the national and local level. In the interest of time, again, I'm going to provide a very brief bio on each of these individuals and encourage you to look at the full bios that were provided to you in your agenda program. First, we're going to hear from Joy Burkhard on the state of maternal mental health care. Joy is the founder and executive director of Policy Center for Maternal Mental Health, formerly known as 2020 Mom, a nonprofit social change organization aggressively working to close the gaps in maternal mental health. Our next speaker is going to be Casey Rivas. Casey will present on the March of Dimes Mom Baby Action Network, leading change across policy, research, funding, and systems. Casey serves as the Associate Director of Strategic Partnership at the March of Dimes National Office, where she co-leads efforts to engage cross-sector partners and build a national movement to achieve maternal and infant health equity. Our third speaker is Zeta Deldoff Picoro. Zeta's presentation is titled Working Upstream, the Role of Politics and Policy in Parent and Child Health. Zeta serves as the Health Policy Advisor to Governor Katie Hobbs. In this role, Zeta recommends systemic change, policy solutions, and implementation strategies to improve health and healthcare for all Arizonans. Prior to this position, Zeta worked as the Health Policy Director at Children's Action Alliance, where she advocated for better access to affordable, high-quality healthcare for children and families throughout Arizona. Please help me in welcoming Joy, Casey, and Zeta.
Thank you again for the warm welcome introduction, and it's my pleasure to be here. I want to start with just disclosures. There's no personal financial interest that I have. We do have event sponsors that support us, including Sage Therapeutics and Organon in the pharmaceutical and device space. I always like to start off talking about maternal mental health with these statements. Did you know that women in their childbearing age years account for the largest group of Americans with depression? Did you know that the American Academy of Pediatrics has noted the prevalence of depression and anxiety in teen girls is skyrocketing? I know you know that. Did you know that maternal depression is one of the most common complications, or is the most common complication of childbirth? And if you add the other maternal mental health disorders, it certainly is at the top of the list. Did you know there are as many new cases of mothers suffering from maternal depression each year as new cases of breast cancer being diagnosed? And despite the prevalence, which we'll talk about in just a moment in more detail, maternal mental health disorders largely go undiagnosed and untreated here in the United States. So a little bit more about the prevalence. Wanted to share that up to 56% of those living in poverty experience postpartum depression. No surprise there. Distress is a leading factor, of course, in suffering. Almost half of adolescent girls, as we mentioned earlier, struggle with mental health, and these are our childbearing age women who may be having babies shortly. And so what are we doing to address those who are already suffering? Rates of depression are more than doubled in the Black population due to communitive effects of stress called weathering, and of course, systemic racism and all of the factors that are at play in the Black community. Also, our Native American sisters are suffering at high rates as well. We have a new issue brief and fact sheet on this, which I'll drop into chat in just a moment. Up to 1 in 5 in the general population will suffer from a maternal mental health disorder like postpartum depression. Research shows that less than 15% will receive treatment. And then 1 in 4 will experience depression during pregnancy. We often forget about pregnancy and focus only on the postpartum. And we like to remind folks that it's not just depression and it's not just the postpartum we're talking about when we talk about maternal mental health disorders. And then we talked a little bit about the poverty statistic already. So I also like to share, what term should I use? I hear different words and terms when I hear about maternal mental health. And we wanted to share a little bit about what we advocate for using and acknowledge that it gets complicated when we're all using different terms, kind of the nature of the beast in our space. But postpartum depression, as I mentioned, was the first disorder to be researched widely and so most often referred to in the news and by providers. But we actually believe it's the wrong term to use as an umbrella term because we actually can do harm when women are suffering from anxiety, for example, in pregnancy. Calling everything postpartum depression is problematic. Perinatal mood and anxiety disorders are often used by behavioral health clinicians in particular, but the acronym PMAD has become a no-no, and I think for obvious reasons. The field is trying to avoid that acronym. So if clinicians do use that term, encouraged to spell it out. And maternal mental health is a term that has been somewhat widely adopted by the field. It's easy for non-clinicians and clinicians to understand, leaves no disorder or time period out, and is hopeful. And also just acknowledge it sits within the broader maternal health field nicely as well. From hearing from other colleagues as we have so far today. I wanted to share a little bit about what the national clinical associations are doing around maternal mental health. We always like to acknowledge the American Academy of Pediatrics is the first professional association to recognize the impact of untreated maternal mental health disorders, specifically postpartum depression, on children. If some of you have seen the headlines of late, the last week or so, there have been a couple more studies that validate that the impact of untreated maternal depression and anxiety on impacting preterm birth and low birth weight deliveries. It used to be called the number one cause of preterm birth by the researchers out of Washington, University of Washington, but now I think we're very much solidified that that is the case with this new research that has recently come out. So certainly an impact on child development, not just the mother's mental health and family stability. ACOG, the American College of Obstetricians and Gynecologists, has come out with some really important new resources. Just recently, this last month, released the first clinical practice guideline for maternal mental health disorders, which some people are shocked that there wasn't a guideline before. You can find that guideline on our website, and it'll take you to the ACOG website. The AIM bundle, which those of you in the perinatal health space or maternal health space probably know what AIM is, the Alliance for Innovation in Maternal Health, and bundles are sets of tools that are released to support perinatal quality collaborative efforts, hospitals, and others in maternal health. The bundle was re-released with measures attached to them just this last year. Earlier this year, rather, and we encourage you to take a look at those as well. And we'll talk about the measures in just a moment, recognizing that there's a new HEDIS measure that is tied to implementation of that bundle. The recommendations initially from ACOG are listed here as well. ACOG really helped put the issue back on the map and triggered the U.S. Preventive Services Task Force to relook at their position on screening. And they did overturn their exclusion of pregnant women in their recommendation prior to 2017 to have screened for depression. Pregnant women and postpartum women are now in that recommendation. And just this last year, the U.S. Preventive Services Task Force expanded their recommendation for the whole population, including pregnant and postpartum women, to also include screening for anxiety. And then also there's a U.S. Preventive Services Task Force recommendation to screen for those who are at risk and provide interventions to those at risk on commercial insurance. This means there's no cost for those interventions. It doesn't mean that all of that is happening just because there's a recommendation that it happens, and we'll talk about that in just a moment. So a little bit about coverage. All of us are following that now that Medicaid has extended postpartum coverage through the first 12 months postpartum. Many states, including Arizona, has done work there, which is incredible. We just like to point out, though, that coverage doesn't mean that the system will deliver the care that it should be. It's an important first step, but there's still much more to do around implementation, not just of maternal mental health care, but all maternal health care. So let's talk a little bit about measurement. What is happening with regard to maternal mental health screening, which is how we identify who's suffering or who may be at risk, and referral and treatment. So I like to point out that depression screening or mental health screening in America is very low generally, sadly, in this country, even post-pandemic, and given the severe state that we're in with our young children and teens, because of some complex system set up in the US with regards to mental health being carved out of our healthcare delivery system, and happy to address more questions about that later. So you can see here, these first two statements here are just illustrating how low screening is in general in the United States. And we like to point out that there is now a new HEDIS measure, and I invite you to learn more about HEDIS on our website if you want to know more. But this is deployed through health insurers and payers, so Medicaid plans and also commercial insurance or private insurance plans collect how often obstetric providers, for example, it's not limited to OBs, are screening, and they can do that in a variety of means. There's also a new HEDIS measure around follow-up, so not just screening, but follow-up. This will likely be mandatory next year for all Medicaid plans through the Medicaid core set, and then also commercial insurers this year as well. And I'm going to take you to the next slide, which shows the rates. How are we looking in terms of screening rates? Last year was the first year that those who voluntarily reported this measure to NCQA, the National Committee for Quality Assurance. This is what the results look like. And not surprising, you can look at the comments on the far right column. The rates were all less than 20% in pregnancy and in the postpartum period, regardless of whether it was a Medicaid or commercial plan. And it is interesting to see that the rates are slightly higher for Medicaid plans, and points to the fact that we need to do more with commercial and private payers as well. So what do we believe? There's no simple answer here. There are 100 levers, we say, that need to be pulled. About 30 to 40 of them have been pulled, are being pulled. There's still more work to do here to solve for this problem here in the United States. We address treatment shortages, that they need to be addressed with urgency. That includes building out the number of mental health providers, like therapists that are trained in maternal mental health. There's some great work happening in Arizona with the Postpartum Support International chapter, other leaders who've been in the space for a long time, and the Fourth Trimester Project, for example. So we appreciate the work that you all are doing in Arizona to build up treatment with urgency. And also, we believe that there should be a test, and there is now a test for providers who are trained in maternal mental health to be board certified with the PMHC, it's called, and that insurers and payers can start to look at network adequacy. We know that Access is working with the leaders I mentioned, the organizations I mentioned earlier, to look at network adequacy, which we applaud. And then we finally want to illustrate that, payers, we talked a little bit about insurers and Medicaid agencies can do some great work here, and really are key to, in our complex health delivery system, to ensuring that change happens. Looking at reimbursement for screening, for example, in obstetric settings, and what the state's policy is around payment, I think is critical. And there are other steps payers can take. And also hospitals are key in educating moms and families, staff doing grand rounds and training for OBs and other providers, including ER providers. We don't want to forget when maternal suicide is one of the leading causes of maternal mortality, along with SUD, form the leading cause of maternal mortality in the US. So really important not to leave out ERs. So we also just want to acknowledge that there are root causes that need to be addressed, right? We can't just be at the end of the stream catching mothers and hoping that we do right by them, but we need to move upstream and address social determinants as well, including poverty and social support, some things that I'll talk about in the next slide. We call this the 7 S's, and really think about this both as sort of root causes and then systemic change in the health delivery system that needs to occur. So women, we all know women and other birthing people need practical support. That means all hands on deck with support in various ways. This can happen through systemic systems or social systems. Social support is the next piece of the puzzle here, and that means relationships and people that understand me is critically important to prevent and support those with maternal mental health disorders. Self-care, that mothers need to be empowered to focus on themselves too. And what does that look like? It can't happen, of course, without the support systems that we just talked about, but something we want to emphasize nonetheless. And then screening for maternal mental health disorders. We have a whole page on our website, a couple pages of screening tools, timeframe recommendations, and more that we encourage you to look at that actually really align with the guidelines that ACOG has recently released, which is great. Systems integration, that means mental health and more, but in particular, mental health being integrated in medical systems, including obstetric clinics and hospital settings. What does that look like? The bifurcation of our mental health system from our medical care system is a significant barrier, yet there's still some things that we can do to address systems integration. And then stepped care. Right now, when a mother speaks up or an expectant birthing person speaks up about mental health or is screened by an OB, for example, OBs are often left in a pickle and able to either prescribe medication or refer to the ER. That's how it feels for many obstetric providers, and we don't have enough of a continuum of supports in between. Of course, we have talk therapists, we have some outpatient treatment programs being developed. I know there's an opportunity to do more of that in Arizona, but some of that has started. And then also development of an inpatient treatment program that's specific to maternal mental health. So stepped care is really important. And then finally, we do also want to address tech solutions. Some mothers, especially young mothers, of course, lean on tech solutions. Where are we leaning in? I'd just like to share that there's some great policy efforts happening. Certified peer support specialist is an untapped workforce for maternal mental health that we want to encourage all of you to explore. Michelle Lacey can talk to you more about the use of peers in Arizona if you're interested. And there's briefs and scaling change that we're focused on. And then to close out my remarks today, I want to share a little bit about the national report cards that were released this year that gave every state a grade. I like starting with this slide because you can see Arizona is actually in the top tier of states, and you earned a C. I think at the color coding, I'm just realizing is actually off here. It should be the lime green for Arizona that earned a C in your state. And you're welcome to take a look at the measures in more detail here on our website. And here is a quick snapshot of the measures on the right. We won't go through them in detail today, but you can see where some of the gaps lie with regards to those measures. There's also a risk and resource map we want to encourage you to take a look at to see where Arizona lands. You can see the bubble here on this map represents the providers, and the dark shades of purple represent the risk. So there is a need to bring more providers to high risk areas in the state. And lastly, I'll invite you to take a look at our issue briefs and our policy positions. We also host an annual conference in March, which many of you have been a part of, which we are grateful for. And there is our website. I invite you to stay in touch and look forward to the conversation at the end of today's session.
Thank you, Joy, for that wonderful presentation. I'm so pleased to see that Arizona is not at the bottom of that report card, if you will. I think that that's really important and to be celebrated in Arizona. So that's just wonderful to see. And thank you for sharing that piece of information with us today. Really appreciate all the resources that you have. So we're going to hold questions for you, Joy, until the end of the presentations. Wanted to invite Casey Rivas now to join us.
Thank you all so much for having me today. I did want to give a quick little caveat. Due to unforeseen circumstances, I was brought in kind of last minute to give this presentation today. So I do work at the national mission level for the March of Dimes, and I am not fully prepped on the Arizona background, but I am going to share today about the Mom and Baby Action Network and talk about how we're leading change across policy, research, funding, and systems. I don't have anything to disclose today. And just quickly to share a little bit about what I'm going to talk about today. First, giving a quick reminder, high-level overview of maternal infant health landscape in Arizona, but you did hear a lot of data already today. Also highlight the impact of social, contextual, and environmental influences on birthing individuals' health, highlighting their role in health disparities, and why the work that we are doing with the Mom and Baby Action Network and our National Equity Framework is so important, and how we are driving towards achieving equity in maternal and infant health. So first, for those who are not familiar, the March of Dimes mission is to fight for the health of all moms and babies, regardless of race, gender, geography, and wealth. And we believe that every mom and baby has the right to the best possible start. The way that we are achieving that very audacious mission is through three distinct goals. First, eliminating preventable maternal risk and deaths, eradicating preventable preterm birth and infant mortality, and in all of this, looking towards ending the health equity gap. So this is just a quick reminder. Earlier in the summit, you received updated data from the Arizona Department of Health, and this is reflective of ADHS's 2022 report. But I did want to highlight that the trajectory for maternal infant health mortality morbidity continues to increase, and the leading causes also continue to trend in the negative manner, especially for Black, Indigenous, and people of color. Of note, the preterm birth rate is the highest the state has seen in a decade, as well as maternal mortality, infant mortality, and preterm birth rates for Black women and infants continues to be much higher when we compare to other populations. And additionally, we continue to see stark disparities in health outcomes for Indigenous women compared to white women. So I just wanted to note those things as we move into this presentation today. So why are we so focused on equity with the March of Dimes as well as Mom and Baby Action Network? Well, the urgency of prioritizing health equity stems from the glaring disparity between our aspirational vision for the well-being of mothers, birthing individuals, and infants, and the stark reality that is faced by families, particularly those who are Black, Indigenous, and residing in underserved maternity care deserts or reliant on Medicaid coverage. Our focus together must be unwavering as we endeavor to reshape the very foundations that impact wellness, transcending the boundaries of race, ethnicity, location, and socioeconomic standing. And our journey to ensure the healthy births for all really starts before pregnancy, looking upstream, and it's linked to one's life course and reproductive health. We need to ensure that everyone has everything they need, resources, economic, political, social, and environmental. So they're set up for a healthy start and a healthy outcome. On the right-hand side, you can see the Maternal Vulnerability Index. This was included on the 2022 preterm birth report card from the March of Dimes. The MVI, or Maternal Vulnerability Index, looks at each county and prescribes a number from 0 to 100 on the vulnerability for adverse maternal health outcomes. It's based on numerous factors that are broken down into 6 themes, including reproductive health care, physical health, mental health, substance abuse, general health care, socioeconomic determinants, and physical environment. The one thing to note here with Arizona is that all of the counties are either in the moderate, high, or very high MVI scoring for adverse maternal health outcomes. So although there's areas of very high, it is something that needs to be addressed across the entire state and all counties. So how does March of Dimes do this work? Well, March of Dimes advances health equity by championing comprehensive well-being for individuals, babies, and families throughout the pregnancy journey. This encompasses preconception, pregnancy, birth, and postpartum care. We do this through a multifaceted approach. So we advocate for policies, conduct research, leverage data, and implement initiatives that directly address health disparities. We also do this through leadership and collaboration. We take an active role as a prominent voice, leader, and facilitator in the pursuit of health equity. We are an equity-focused operation. We operate within the framework of equity, inclusion, and justice, both in our organization as well as how we work with our partners. And then we also do this through innovation and accountability. We support innovative solutions and consistently monitor our progress, ensuring effective strides in closing the health equity gap for moms, infants, and families. Oh, I didn't realize that was a click-through slide, sorry. All right, so let's take a look at how the Mom and Baby Action Network is expanding the picture to look at health equity and work with partners in cross-sector organizations. So first, I want to share the Mom Baby Action Network vision. Together with our partners, we aim to achieve equity in maternal and infant health outcomes by centering the voices and experiences of local communities and mobilizing our partners around a common agenda and shared metrics of success. The Mom and Baby Action Network was built on the achievements of the National Prematurity Collaborative, which was launched by the March of Dimes in 2016 with CDC support. And it really expanded the lens beyond just looking at preterm birth and recognizing that we needed to look upstream and we needed to include both mom and baby in all of the solutions that we were working on to advance health equity. It engages cross-sector partners to invest in, influence, and leverage collective action to address the root causes of inequities in maternal and infant health. And we recognize that to do this is a complex and multi-layered process, and it requires us to have very close and high alignment with all of our partners so that we can move from just looking at the data, but moving towards action. Through MBAN, March of Dimes is leading broad measurable changes in all of these areas that I've discussed: policy, research, funding, and systems. And you can see here our tagline is "Together we can achieve what we cannot achieve alone," and we truly believe that. So let's take a look at our national equity framework. All of our work is grounded in this framework. It was co-created with our partners through a highly engaged process. It included over 600 different individuals, organizations, and partners. It included surveys, facilitated data-driven discussions, and community listening sessions. And it's anchored in our agreed upon results statement, which is that all people are healthy before, during, and after pregnancy, and if they give birth, they have healthy outcomes. The framework includes a set of shared metrics, population indicators, both maternal health indicators as well as infant health indicators such as preterm birth, low birth weight. On the maternal side, looking at things like hypertensive disorders of pregnancy and others, and all stratified by race and ethnicity. We also look at performance measures. So we want to know how well we're doing. We ask the questions of how much are we doing, how many people are we reaching, and if anyone is better off. Because it doesn't matter if we're doing all the work if we're not actually helping people, right? So our framework is rooted in 5 root cause strategies that include dismantling racism and addressing unequal treatment, increasing access to high quality healthcare, promoting environmental justice, advancing economic opportunity, and building safe and connected communities, with the recognition that racism and unequal treatment runs a string through all of these strategies. But we also recognized that it was important for it to have its own standalone strategy with a group of solutions to advance equity across the space. Each of these strategies has a crowdsourced set of solutions that include policy and systems, data and research, programs and services, communications and training, and funding. Because these solutions are crowdsourced, these lists are ever changing. We're always looking for new evidence-based and innovative solutions that we can add to this list that we can all move forward together. So to share a little bit about what makes up the Mom Baby Action Network, to be fair, these numbers are a little dated. So we currently have over 400 individuals representing over 300 unique organizations. Those folks come from many different types of organizations, including federal and state agencies, professional associations, community-based organizations, philanthropists, academia, and others. We work with many different sectors. So we know this work means that we have to work with not just public health, not just healthcare, but we also need to be working with, food security, communications, environmental health, consumer goods, education, law, and others. Currently, we represent over 40 states, territories, and countries, and our goal is to have representation from all of the states and territories within the United States. We do our work in 2 different ways. So together, MBAN and our partners, we have work groups in those first 4 strategies. We have active work groups where we're taking action on collaborative work plans to advance changes across those crowdsourced solutions. So together we identify a solution that we think we would like to advance, and we have the capacity to advance, and we do that together in our work groups. And then as individuals and individual organizations, we also ask that our partners adopt and implement the National Equity Framework strategies and solutions in their own work that they're doing, so that together we're accelerating birth equity. So I do want to share a quick snapshot of what some of these proposed solutions look like. So here you're going to see a snapshot of proposed policy and legislative solutions from our Dismantling Racism and Unequal Treatment strategy. The list here is just a snapshot. We have a whole bunch, but I did want to share an example of what one of those solutions might look like. So one of the solutions is requiring collection and reporting of disaggregated data by race and ethnicity. And the reason why this solution is on this list is because we know that when we better understand and identify the data, then we can better understand what's actually happening in health disparities, and it can lead to better resource allocation, more effective interventions, increased cultural competency for those who are serving populations, as well as accelerating advocacy and policy change, because we know when we have clear evidence, it leads to more effective action and push for changes to promote equitable outcomes. So like I said, we have many more different proposed solutions from our partners, but this is just one example that we feel is very important and we're collectively working toward. Another example I want to share is a snapshot from our increasing access to high quality healthcare. And this example is great for Arizona because I know there's currently a push for increasing equitable access to doula care through adequate insurance coverage. And we know with doula care that you have increased emotional and psychological support, which leads to a reduction in anxiety and stress and fear, a more positive birthing experience, which can also lead to better mental health outcomes for mom and baby and better health outcomes. We know it also leads to improved communication and advocacy between medical providers and the birthing person. Doulas can help empower individuals in understanding their options, making informed decisions about their care. They can also act as advocates to ensure that an individual's preferences and concerns are respected by healthcare providers. We also know that doula care leads to reduced intervention rates and reduced time and labor, which helps with reducing healthcare costs. So it's a win-win for everyone. And then quickly, I just wanted to share all of the strategies have similar solutions, and many of the solutions actually run across multiple strategies. So we are going to be rolling out a national equity framework guide in the coming months. It's going to have an overview of all of these strategies and the potential solutions, as well as some examples of solutions in action to help organizations, individuals, take a look and find things that they can do in their own work to advance health equity. And we're really excited about that work that we are doing. And then beyond MBAN within March of Dimes also has its own large federal policy priorities. MBAN is working in concert with our Office of Government Affairs to also advocate for these policies, but I wanted to share what March of Dimes is doing at the federal level as well. So the three main priorities for 2023 through 2024 are increasing access to quality healthcare. This includes advocating for Medicaid postpartum extension, access to midwives and doulas, and access to quality telehealth services. And you can see where that string runs, where access to midwives and doulas, MBAN is really working in that space right now. And so that kind of runs a string with our national federal work as well. And then the second is support healthy women and babies. So access to mental health services and workplace policies for families, where we saw really great progress last year with the Pregnancy Workers Fairness Act being passed. And then improving research and surveillance. So that's supporting things like maternal mortality review committees, newborn screening modernization, and vaccination compliance. And then finally, here's a snapshot of, again, our March of Dimes report card includes policy measures on it that we believe when organizations and states are implementing these policies, it can improve maternal and infant health care. And this is Arizona's snapshot, and it's great because we have lots of green check marks, and then we have that doula policy legislation that is pending or in progress, which is good to see. So I do want to note one thing, even though these things are checked off, what we are seeing kind of across the board, especially with the Medicaid extension beyond 60 days postpartum, is that all those states have, it passed this legislation, passed this policy. There's other important steps included that need to happen. And part of that is awareness. So we need to make sure that the pregnant people, postpartum, they know that they have access to Medicaid beyond that 60 days postpartum. And so ensure that they are aware and are utilizing the services that they still have. So there might be some awareness campaigns that need to happen in the state to ensure that people know that they have access to that, and then ensure that providers know that as well. So that's just an example of, you might have passed a policy, and this is happening in states across the board, but you still have work to do to ensure that that policy is communicated and being utilized in the way that it is meant to be. So just a few key messages. I think everyone's here for a reason. I think we know that the US remains among the most dangerous developed nations for childbirth. There's a higher chance of maternal death or preterm birth based on race and ethnicity. We know that social drivers, it says here, play a significant role, but social drivers of health are the key role in perpetuating inequities among Black, Indigenous, and people of color. And it leads to long-term multi-generational effects on families down the line. MBAN is a consortium of multi-sector national, state, and local partners, and we're committed to addressing inequities in maternal and infant health. And we do that with our 5 cross-cutting strategies. And again, we do have 4 work groups that currently meet bi-monthly. Those are the dismantling racism and unequal treatment, increasing access to high-quality healthcare, promoting environmental justice, and we just kicked off our advancing economic opportunity work group this summer. And we are hoping to kick off building safe and connected communities sometime in the future. And then we know that achieving meaningful change across these strategies necessitates active engagement and collaboration with many different partners and stakeholders across policy, research, funding, and systems. And I just want to remind you of our tagline: together we cannot accomplish what we cannot achieve alone. And When you get this slide deck, you'll also get this resource list, but I invite you to, if you're interested in taking part in the Mom and Baby Action Network, everyone is welcome who wants to advance this work together. And we don't just work at a national level, we do work to amplify, replicate things that are happening at the community and local level as well. So thank you all so much. And I will pass it off to the next person.
Thank you so much, Casey. Really appreciate you sharing your presentation and that wonderful overview. Really love that slide with all of the examples of policy opportunities. Very helpful. So now we're going to stay tuned, Casey, because we're going to have questions at the end of the next presentation. Next, I would like to bring Zeta up to the stage, please.
All right, so I am really grateful. Casey's presentation and Joy's presentations just led straight into what I'm hoping to talk about today, which is some of the state level policy priorities for parental and child health that we're experiencing and where we still have some work to do. So quick conflict of interest disclosure. I am employed solely by the state of Arizona. I serve at the pleasure of Governor Hobbs. And beyond that, I do not have any conflicts of interest to share with you all today. So before we get started, I'm going to just share our objectives for this presentation. We want to understand how state laws, how state policies, and how practices that are associated with those laws and policies impact the health of people during, before, and after pregnancy. We also want to know how those laws and policies influence parental and infant health throughout the lifespan. How does policy change influence our behaviors and beliefs about healthcare? And then why does state and local level advocacy matter? So let's dig right in. I am going to be very honest with you. I am not a graphic designer, so bear with me as we talk through a little bit of a parable that somebody had shared with me early when I started working in policy. And I will tell you, I stumbled into this on accident, loved it, and never left. And part of that was, I think policy helps us accomplish on a much larger scale changes that are needed to shift outcomes for individuals who may not have any idea that those things are going on around them, right? So this is the parable of the babies in the river. I'm going to tell it a little bit differently every time. I apologize if you've heard me tell this story before, but there's this village, it's on a river. The river is the center of life for the village. Everyone washes their clothes there. They get water for their homes there. They go and hang out there. And one day there's a group of villagers that are there and they see something kind of coming down the river and look and realize that it's a baby, right? And so they go into full lifeguard mode, swim out, save this baby, pull it out of the water, warm it up, give it some food, find a home for the baby, make sure it's taken care of in the community, really wrap themselves around it, right? The next day they go out to the river and they're doing all the same things and two babies come floating down. So they go through the whole process again, they grab the babies, they rescue them immediately, they get them, their basic needs equipped, find them homes, do everything that they can to support these children. And the day after that, there's 4 babies. And the day after that, there's 16 babies. And I don't know what comes exponentially after 16, but that is, it just becomes this massive trend that they're seeing where every day there's more babies and they're really starting to feel stretched. They're out of homes. They don't have enough resources to feed everybody, but they're really trying to do their best. So they set up schools that teach babies how to swim. They set up group homes for these babies to live in and get education in and, teach them the ways of the world. And then it really reaches a tipping point where there are so many babies coming down the stream and they've got every hand in the village there trying to save them. And one of the villagers just like straight up walks away in the middle and is like, I'm not doing this anymore. And the other villagers are like, what are you talking about? You need to, we need your help right now. We need you to help pull babies out of the river. And that villager is like, no, I'm going to the town up the river to figure out why these babies are ending up in the river in the first place. So when I talk about kind of upstream and downstream impacts, that's where I'm coming from. And it's really about getting to the root causes, getting to the structural and systemic challenges that we see in order to address some of those downstream impacts. I promised you that I would talk about how policy impacts how cultures function, right? I studied anthropology in school. This is a really helpful way for me to think about the relationship between these words that wind up on papers that get filed in fancy ways in a government office somewhere and the impact on people's real lives. So I like to view policy change as the first step in a cycle. Some of you may be familiar with a model called the Waters of Systems Change. It gets used a lot in kind of like foundation grant making. And it's sort of a theory of change, but it starts with making these explicit structural changes, changing how policies are written, changing how we practice, and changing how payments are delivered, right? Resourcing. From there, we start to see a change in the way that people talk about things. We start to see a difference in the way that they interact with those larger systems and structures. So to give a pretty solid example that I use all the time, indoor smoking, right? Smoke Free Arizona Act. I'm old enough to have worked, during college in a building that allowed indoor smoking before that ban went into effect. And I just want to stress that was a voter-led initiative, very important for public health. We need to do everything we can to protect the initiative process. When that initiative went through, the folks that came to the place where I would work came in every day. They would sit there all day and smoke cigarettes all day long inside, but it was part of how they found community, right? So they had their friends that they would meet up with every day. They'd come and sit, they'd play chess, they'd smoke their cigarettes. And when that changed, when that law went into effect overnight, there was kind of a void for a while, right? People didn't know what to do with themselves. And so what we started to see was a lot of grumbling about having to be 50 feet away from a door to smoke a cigarette. But we also saw a physical change. The space, as the smoke started to clear out, you could see layers of smoke built up on the walls from decades, if not, longer, of people smoking in those rooms. And it really kind of hit in this very visual way what that was doing to all of us on the inside, right? So there was kind of that physical component. People started going outside to smoke too, right? So they started taking their friends, bringing their chessboards, walking outside, grumbling about it a little bit, and that's fine. But they really started getting out more. And from that, I started seeing people going for walks, because once you're outside, you kind of want to, go for a little walk. And moving on to kind of the next phase of this process, that was hard. It was hard for people who had grown up immersed in that environment to make that change and to accept that that change was happening. But now we have a generation of young people, of high school and college students, who have never known that and have never had it be a normal thing to experience indoor smoking. And so when you ask them about smoking, they're like, "Really, that's not cool. That's gross. Like, that's so nasty." And it's really been a fairly rapid change, right? That law went into effect, I think it was 2006. And so we've already seen this pretty significant change happen within a matter of less than 2 decades. From there, that's where we start to see a change in ethos. We start to see a change in more of the implicit ways that people think about their health. But what happened when that went into place? And what do we have to worry about now? We have to think about vaping, right? So we're in a situation now where we don't as a state have a way to define what a vape is. And if we can't define it, we can't regulate it. So we're in a position now where we're really having to kind of start this cycle over again and go through this process once more. I hope that that was illustrative, and I'm going to go ahead and move to the next slide. So I am certain that everyone on this call is very familiar with a graphic like this that really talks about the social determinants of health, social drivers of health, and really makes clear that so much of our health is dictated by upstream factors, right? Things that are entirely out of our control, things like socioeconomic status, experiences of racism and discrimination, community safety, education, job status, family income, even environmental factors associated with particular zip codes, right? But I wanted to also stress a model that, or a framework that I think about a lot, which is the political determinants of health. And I like this model because I think sometimes it's easy to think of social determinants of health and social drivers of health as these like gigantic monoliths that can't be moved, right? They're just there and we just got to figure out how to work around them, and we can maybe put a Band-Aid on here or there, but like, I think that people have a little bit of a sense of defeatism in a lot of ways about addressing a problem like economic inequality, right? It's a big one, it's a heavy lift. When we look at this from a political determinants of health model, it makes it clear that social determinants of health are deliberate. They are structured and they are designed to be the way that they are. And if they're structured that way, they can be destructured, right? If we can build it, we can unbuild it. This is a quote from Daniel Dawes's book. It's absolutely fantastic and I highly recommend it. I'm not a paid spokesperson by any means, but it's just a really good read. So he talks about political determinants of health as this process that goes through, existing systems, existing institutions, and that involves structuring relationships and distributing resources and functionally administering power in ways that influence people's access to opportunity. In turn, that either can advance health equity or it can exacerbate health inequalities. So I wanted to talk a little bit about the state of Arizona. And I will say, these are, again, big issues to lift, but there's a lot of work that we can do and we really need some help to do that and to get there. So in short, state policy matters is all that I hope you take away from this conversation. When we look at socioeconomic factors, we talk a lot about school funding in the state of Arizona. About 40% of school funding in our state comes from property taxes, bonds, and overrides. So folks who live in areas with higher property values are going to live in school districts that have more funding. Arizona spends about $5,900 less per student than the national average. But when we look at predominantly non-white districts, that winds up being about $8,000 less per student. I also want to stress that 1 in 4 kids in Arizona is living in poverty, but only 6% of those who would qualify for TANF cash assistance, the program formerly known as welfare, are actually receiving it. Instead, about 67% of the state's TANF allocation, this is a federal allocation, is used to fund our child welfare system. That is compared to a national average of just 8% going to fund the child welfare system. And what that shows is that Arizona is spending a lot of available resources that could be used to help keep families together to take them apart. I also want to highlight that nearly 40% of kids in Arizona are living in households where a grandparent is chiefly responsible for their basic needs. And as our population continues to age, this is going to be a growing challenge, particularly for individuals who are on a fixed income. And I'll show you a little bit about what that might look like next. Next slide after this one. But we also rank in the top 5 worst states for housing affordability. There are only about 26 units of affordable housing available for every 100 households in our state that are living in poverty. And it is not surprising that the number of families with children experiencing homelessness has increased 15% since 2021. Speaking of the physical environment, we need to acknowledge the realities of our climate crisis in any health policy work that we're talking about. We need to be talking about heat. We need to be talking about wildfires. We need to be talking about flooding, and need to be planning for a generation that is going to grow up in a very different physical world than the one that we grew up in because of human-led climate change. So I love showing people this graphic. This is for Maricopa County. I apologize for the folks who are out of Maricopa County, but this information comes from the Economic Policy Institute, and you can pull county level data for just about anywhere. This is based on federal estimates of the housing and urban development average rent for a 2-bedroom apartment. So let's say we have a family of 4 here. They've got 2 kids. One is in preschool, one is in public school. They don't have any out of pocket expenses for the child that's in public school, but they are paying for childcare. They, have 1 car. They try and use the bus whenever they can. They're out of an income bracket that's going to allow them to qualify for Medicaid. So they have the lowest level Affordable Care Act plan because their employers don't offer coverage. This is kind of a breakdown of what their average monthly expenses look like. And if you round that up to an annual total, that family of 4, 2 parents working, 2 parents in the workforce, full-time, would need to bring in $91,000 a year to support this lifestyle. This is not including student loans. It's not including other kinds of incidentals. This is a very minimal life. It's assuming that they're preparing most of their meals at home. And it's pretty shocking to see. As far as health behaviors go, particularly in the maternal and child health space, I want to share that Arizona is the 3rd largest producer of fruits and vegetables in the country, but 1 in 7 of our residents are food insecure. Let that hit home for you. We are producing so much food and people don't have enough to eat. We can also look at an issue that I know ADHS has been taking very seriously, and that is the rate of syphilis cases, and in particular, the rate of congenital syphilis that is occurring. So we have seen a 450% increase since 2015 in the rate of syphilis cases in women in Arizona. And that has translated to 51 cases of congenital syphilis and 6 stillbirths or deaths of a newborn related to syphilis. That may have been updated since I pulled these slides, but it shows me 2 things. One is that we have some work to do on education, and we have a lot of work to do on prenatal care. This is a simple test, and we can stop this. I also want to share that our vaccination rates for kids entering kindergarten fell significantly behind during the pandemic. They were already behind before the pandemic. And now kids entering kindergarten in this state are well below the levels that we need for herd immunity. Fewer than 90% of kids who enter kindergarten this year have immunity to measles, mumps, and rubella. That's terrifying for me as a mom, and it should be terrifying to all of us as residents of this state. So policy change happens in a lot of different ways. And I'm gonna blaze through this because I know we are short on time. There is, of course, legislative and statutory change. There's also budgetary change. So if we reflect back on those political determinants of health, how we allocate resources is incredibly important to restructuring power dynamics. There's also administrative or regulatory change. And this is the one that is the least sexy, but arguably the most important. I'm going to show you why in just a moment. Real quick before we do that, I want to share a little bit about our legislature. Arizona's state government has 90 members total. There are 30 state senators, 1 per legislative district, and 60 state representatives, 2 per district. And we have what's known as a citizen legislature. So our legislators do not make enough to live on unless they are living a very, very lean lifestyle. They're certainly earning far less than the $91,000 required to rent a 2-bedroom apartment in Maricopa County. And they meet annually. Part of why I mentioned that this is a citizen legislature is that these folks have other jobs, right? So when we're talking about this, they're not spending all of their time investigating maternal and child health, right? We need to be there to coach them. We need to tell them what is important and why. Because if we're not telling them that, they're getting that information from elsewhere and we don't know how reliable it is, right? It's also important to know that, what that means is that we have members of the health committee who have never worked in a healthcare environment, don't have any kind of training in biology or physiology. And that's not necessarily a bad thing, right? That can be a really positive thing. It's, part of, I think, democratization, but it also means that we have folks who really don't have a lot of the background needed to make decisions about health, that are responsible for, drafting laws and creating policies that impact the health of our population at a very broad scale. Whoops. When we first submitted our slides, and I will share out an updated deck, it was, I believe, the end of June. And we had not yet adjourned our legislative session for the year. So I've gone ahead and updated this version. We did not adjourn sine die until July 31st of this year. Typically, the legislative session wraps up somewhere in May. This was a really extraordinary session for a lot of ways, for a lot of reasons, rather. One is that it was more than twice as long as a typical legislative session, which lasts about 100 days. One is also the extraordinary number of vetoed bills that came through. And when we're talking about bills that were vetoed by the governor, I want to make it clear that, as we're making those recommendations, as we're having these conversations behind the scenes, this isn't something that we take lightly. It's not about hitting a record. It's about the bills that we have seen come through really posing a threat to individual civil rights, to public health, to safety, potentially leading to mass incarceration or further mass incarceration. And so every veto that we make is a very thoughtful consideration. I just wanted to make sure that was stated. I think that it's kind of been talked about as like, oh, we'll just stamp anything, but really, there's people whose lives depend on the legislation that is passed by the legislature, and the governor has the ability to kind of intervene there. So every bill starts as an idea. Ideally, there's a stakeholder input process. Sometimes it doesn't happen, but ideally it does. During the legislative session, which kicks off the second Monday of January every year, that bill gets introduced. We have a law on our books that requires bills to be read out loud 3 times to the legislature before they can be officially voted on. It's kind of a relic of a time when our legislature was largely not literate, right? Think back to the territorial days. It was really important that they be able to hear those bills over and over and make sure that they knew what they were voting on. But it's really fun to watch them do this because the guy who reads them and the woman who reads them now in the Senate are just like amazing, and they read through them really fast, and it's really cool. Then they get assigned to and voted on in a committee. So this is really an opportunity to come and testify on that. This is a smaller group of individuals. And I want to make clear the chairs of the committees in the House and Senate have a lot of power. So the Speaker and President have the ability to assign that bill to committee. They can make it really easy for it to get through. They can make it harder to get through. And then additionally, that bill has to be put on a calendar or on an agenda in a committee. And the chair of that committee is solely responsible for deciding what does and doesn't make it onto that committee. After that, it gets voted through one chamber and sent over to the second chamber. It's important to note that this is all happening on a timer. So they have, a particular number of weeks to get everything through the first chamber and then through the second chamber. And then, of course, there's always a workaround and a rule that can be bent is the word, in case of, somebody has a last minute thing come up. So please know every rule in here is meant to be broken. After it goes through the second chamber, either the House or the Senate, the opposite one of where it started, it comes up to the governor's office. And if she signs it, it becomes a law. And that's it, right? That's what matters. The answer is no, because a law is only really a law if it gets implemented. And this is where I think we need to do a lot more to raise awareness of this process and what goes on behind the scenes. So agency heads are typically appointed by the governor. And members of various boards and commissions, whether that's healthcare licensing or another type of board, are also typically appointed. So these are individuals serving in a volunteer capacity. But it's an area where the legislature in some cases, or the governor in other cases, have a lot of authority to choose who's going to make decisions about these issues. The agency's boards and commissions draft
Zeta?
rules. Yeah, I'm sorry. Am I at time?
You are, but I would like to propose 5 minutes, and then we can wrap up. Would that work?
That would be great. I think this is my last slide, potentially.
Thank you.
Yes, of course. Thank you. So these are appointed positions. And I want to just add, if you want to get more involved in policy at the state level, when Governor Hobbs came into office, we inherited about 700 vacancies on about 250 state boards and commissions. So you can apply online. I can drop a link in, but we're really looking for great people who want to do good work in the state to join those boards. After that, there's a public comment period. That rule either gets revised or scrapped, or it gets sent to a commission called the Governor's Regulatory Review Council, which again is appointed. And they review it for impact on everyday Arizonans. Once they approve it, it's approved, it can go into place typically about 60 days after it's approved by GERC, as we say. Sorry, it's a really unattractive acronym. Or there can be a judicial intervention, right? So at any point, the courts can come in and be like, that is not what we were trying to do here. This is not within your power. You can't do this. Or, it can be approved and implemented. And so I want to just stress the importance of commenting on these proposals. It's not always fun. It's not always like the exciting part of doing policy, but it's so important. These are really the outlines of how the laws that get passed at the legislature will be implemented in practice. I'll highlight a couple of wins from the budget this year. I did put in the chat earlier, we did manage to get about $7.5 million to support on-call OBGYN services in rural areas that cannot sustain an OBGYN. And that's really exciting. I think it'll buy us a little bit of time to help develop the workforce in those areas. So it is a stopgap. It's not the end measure. We've also increased eligibility for kids care to 225% of the federal poverty level. Previously, it was 200%. We've got free menstrual hygiene products in schools. We have the largest ever investment, $150 million in the Housing Trust Fund. This is a flexible source of funding that can be used to combat homelessness. And on and on and on and on and on. I'm going to just blaze through. Looking forward, we want to expand access to family planning. We want to ensure that people in every corner of this state have access to affirming and affordable healthcare. There's a lot of work that we're doing on the back end right now to kind of start to initiate those processes. Free and reduced school lunch, right? We need to take some looks at that. We need to make sure that our kids are having the food that they need to succeed in schools, and generally that our schools have what they need to effectively teach our students. We know we need clean air. We know we need clean water, and we need to be thinking upstream as we're talking about all of these factors. So I just want to make it clear, we are trying to work that out right now, and I'm excited to see what comes next.